Hello, everyone, and welcome to the Melanoma Research Foundation Prevention and Awareness Education Session. I am really thrilled to be here today with three incredible people talking about ways that we as a melanoma community can help prevent melanoma and identify melanoma recurrence earlier, which we know leads to better outcomes for patients and our community at large. So I'm going to start with a round of introductions. I'm going to tell you who we're speaking with today and let them introduce themselves. So first off, I'm going to start with Dr. Michael Krainock. If you wouldn't mind giving a little intro for our group.
Sure. Thanks so much for having me today. Kyleigh, very excited to support this MRF initiative and be here with our two co-panelists, Casey and Dr. Poklepovic. I'm Mike Krainock. I'm an associate med director at Natera. I work on pretty much our whole suite of molecular oncology diagnostic tools and do a lot of work in melanoma. So certainly excited to be here today.
Great. Well, thank you so much for being here. I will now move over to Dr. Poklepovic, if you wouldn't mind introducing yourself.
Absolutely, and I'm really glad to be here and participate in this. So my name is Andrew Poklepovic. I'm a medical oncologist in Richmond, Virginia at the VCU Massey Comprehensive Cancer Center. I've been taking care of patients with melanoma for the past 15 years, and I run the clinical program for cutaneous oncology for Massey. And I'm the associate director for clinical research there as well.
Wonderful. And last but certainly not least, Casey Stock.
Thank you so much for having me today. I'm Casey Stock. I am a Natera employee and I'm also a Natera patient. I am a two-time melanoma survivor. I've lost my parent as well as a grandparent to melanoma, and I am in the midst of an ongoing cancer journey. So thank you for having me today.
Thank you for being here, Casey. Thank you for being so vulnerable and for sharing your story with our community and really giving a lot of hope to a lot of patients out there. So thank you for being here. We are going to start off talking a little bit about sun safety and secondary prevention. So I'm going to kick it off first with a question to Dr. Poklepovic. You see patients in clinic, obviously, you see melanoma patients, and one of the top questions on melanoma patients' minds is, how did I get melanoma to begin with, and how do I prevent future recurrence? So what do you share with patients in terms of sun safety? What are your tips for them?
So it's really about avoiding excess UV exposure, minimizing it when you can, making sure that you sort of frame your life around not taking unnecessary risks for being out in the sun. And so we spend a lot of time talking about things like in Virginia, there's something called a DMV sun shading form, which allows you to get tint on your windshield and on your driver's and passenger front windows, which are not normally allowed in the state of Virginia. But with a waiver, you can now block 99.9% of UV radiation getting into your car. And that's an area where people get that. People are like, oh yeah, this is where my melanoma was. It's on my left arm, or it's by my left neck and ear. Certainly on the driving side, we talk about UV protective clothing, which has really become kind of ubiquitous now. There are sun clothing brands that were developed by people whose families have been impacted by melanoma, and they really, have high quality material. It feels good. It's lightweight, and I wear that stuff myself. I go forward and I tell patients, this is what I do when I'm going to be outside. I have this type of lightweight, even if it's warm. You wear a hat with the hood up, and you're going to be fine for hours. And then it's about, daily sunscreen protection. I try to overcome some myths about sort of vitamin D deficiencies and, you must be laying out in the sun all the time. You really don't need to be. It's just a few minutes of incidental exposure, which basically happens to everybody to get sufficient amounts of vitamin D. But, there's always a cultural trend line towards wanting to have more sun, wanting to have more tan. You'll see that in kind of outdoor magazines. It keeps you from feeling depressed. And so how can you be outside and do the things that you want to do and be active, but also be smart and safe about it?
Yeah, no, those are great tips. It's great that Virginia has that because you're right. I don't know if you've ever seen where you can basically take a photo and see where your sun damage is, and a lot of people have it on the side that's facing the window where they're getting a lot of that UV exposure. So those are great things. So hopefully our Virginia listeners will get that waiver. Casey, obviously this is top of mind for you, who's been personally affected, and your family as well, what are some of the routines that you have to protect yourself on a daily basis? Because living in Denver with the altitude, you have a lot of UV exposure there.
Yeah, it's a double-edged sword because we also have 300 days of sunshine, which is amazing because we have 300 days of sunshine, but it's also we have a lot of sun and then we're also closer to it. So I'm also a big fan of the UV clothing, especially spending time outside. I hate to say like they make it very fashionable these days, so it doesn't give you an excuse to opt out. I've also grown up with long sleeve swimsuits. That's just the way it was, especially with the reflection on the water. And then my family is really big with reapplication of sunscreen. We put timers on our phones when we're outside. And then we have sunscreen in all bags, whether they're sticks, whether they're lotions, but they're kind of in every single bag. We do not leave the house without it. And it's just part of the daily skin routine and explaining to our young children why it's important as well. So we've found some tips and tricks on the internet too on how to apply sunscreen to kids so it's not so burdensome and also somewhat fun.
Brushes are really good to
That's
apply
what, yeah,
the
makeup
goopy
brush.
sunscreen. Yeah.
My kids think that it's not a makeup brush. They think it's a sunscreen brush, which I
Yeah.
won. So yeah.
Well, that's great. Well, I think, we talked a little bit earlier about a lot of myths. The vitamin D piece is certainly one that's floating around there. So, Dr. Krainock, like, what's a common myth about sun exposure after melanoma, and how do you explain that reality in simple terms?
Yeah, I mean, and I think Casey and Dr. Poklepovic could weigh in on this too, but I would say, something melanoma survivors deal with a lot is having to live life realistically after their diagnosis and treatment. I think maybe some survivors feel like they have to never see the sun again, and that's just not practical. We live, like Dr. Poklepovic said, such that we're exposed to the sun all the time. So I think being realistic about mitigation, but also maintaining a quality of life and doing the things you love to do, and not living in fear because you have survived melanoma, but being very strict, as Casey pointed out, and regimented and disciplined with sun mitigation measures like UVA, UVB clothing, like the proper application of sunscreen in terms of how much you're putting on, how often you're applying it, following your provider's instructions on those types of things, and of course maintaining your skin surveillance both as it relates to your known treated melanoma and any other lesions that might arise on your body. So I think that's what I would point to as something that is realistic counsel for patients who have survived melanoma.
Yeah, no, really, really great advice. We're going to switch gears a little bit. And Casey, you brought up how melanoma has not only touched you, but family members as well. And so I want to talk a little bit about hereditary risk and family history. It's certainly a question we at the MRF get quite frequently. So Dr. Poklepovic, let's start with you. What are some of those red flags that make you consider hereditary cancer testing for melanoma? It's certainly something that we get asked quite a bit. And obviously, when someone is diagnosed, if you're a parent, you immediately go to your children, and you want to get those answers. So, what are some of those flags for you?
Well, I think there's two ways to think about sort of the hereditary risk. And one is, did you inherit a gene that puts you at excess risk of melanoma? And there are several that can be seen. Most melanomas don't fall into that category. There are some rare mutations like things called BAP1 and CDKN2A. But really, there's this other hereditary thing in this, where did your ancestors come from several hundred years ago? And was it Scandinavian countries where it was dark for 6 months out of the year and cold and people were bundled up and really didn't have a lot of exposure? And now you're living in a place like Arizona or,
Yeah.
Denver, Colorado that is at altitude with lots of sunshine, right? Your ancestral ability to take UV rays is different. So there is the ability to say, I have a heightened risk of melanoma. I've had multiple family members with melanoma. I've had multiple melanomas myself. I had one when I was young. Those all raise the concerns for genetic testing. And then there's the whole, I have fair skin and blue eyes, and my whole family gets lots of skin cancers, and we, live in Australia, and that's kind of what happened in Australia. You took people from, Northern Europe and England and Ireland where it wasn't all that sunny, and you put them in one of the sunniest places on Earth, and that's where they had the highest melanoma incidence. So there's two pieces of it. It's what is your skin capable of tolerating in terms of direct exposure to UV rays? And then do you have something else that adds another risk to it? And so, you don't have to be fair-skinned to get melanoma, but natural pigment and how dark your skin is does relate to that. So there's about 100-fold difference between, a black person in the US and a white person in the US in terms of their background risk of
Mhm.
melanoma. So that plays a role, but it is different from a broken gene that you inherited that puts you at an even greater risk.
So how do you, I guess a follow-up question to that is how do you counsel your patients then? Is there sort of a criteria that you follow and you say, I'm going to recommend this for you or I wouldn't recommend this for you? What is your threshold on that?
Well, I use a lot of sort of their heritage as kind of an explanation. Most people, the modern awareness of sun hygiene and how to protect yourself from skin cancers was not something that was being taught to children in the 1980s and even into the 1990s. This is something that is being taught to children now. And kids are growing up with long sleeves and kind of following the Australia sun hygiene model with hats and things like that at the beach. Um,
Hmm.
but if I have a patient and when I take a family history, if they have, a brother and a mom that's also had melanoma and they have one as well, and maybe there's somebody else who had pancreas cancer or something that might raise, there's a handful of things that say, okay, we're going to send some genetic testing on you, because that may mean that your risk is even higher, or we may should also be screening for other conditions as well, and can impact sort of other family members for how they go about testing.
Casey, obviously, as a patient yourself with family members that have had this disease, that I'm assuming that's what led you to want to do the testing. Um, but how did knowing your risk change your plan or conversations with your family? Because I'm assuming that's a lot of information to adjust and then to relay it back to your family. What was that like for you?
Yeah, I would say my family risk wasn't initially the predominant reason why I got the testing. So I lost my mom when I was 4 to
Mm.
complications for melanoma. She had a very severe case of melanoma. And then the other challenge with that was she was also adopted. So we didn't have a lot of family history on her. At the age of 32, I was 6 weeks postpartum. My OB actually found my melanoma and
Mm.
advised that I get it checked out. And it turned out that it had expedited and changed significantly during my pregnancy. I had been doing annual skin checks my entire life. And it turned out to be an invasive malignant melanoma. There was some other spots at that time that came up as myelodysplastia, pre-melanoma, and it wasn't until about a year later that it was advised from a dermatologist, like, "Hey, I think you're missing a piece of your puzzle. I think you need a bigger picture of what's going on."
Yeah.
And then that was when it was recommended to actually pursue hereditary testing, it was very serendipitous. I just started at Natera and I felt like my worlds were colliding. And
Yeah.
the other reason being is that my father had also passed from cancer. And so there was just a
Mm.
lot from my oncology background, especially from family history. They're like, we're kind of shooting in the dark here. Like, you clearly have family that, originated from Scotland, you're in Colorado. So anyway, when I received my results, I do have the mutation, the CDKN2A, with the mutation for the increased likelihood also of pancreatic cancer, which is also very much of a concern. It was a little bit of a relief understanding why it was happening, apart from, I've always taken very preventative measures of my skincare, but why it was happening. And then also to get my siblings tested, which was also instrumental because my sister also has kids. So, if anything, it's also helped to just inform my full oncology journey, not just my skin, but also my pancreas. And at this point, I couldn't imagine not knowing. It's one of these things that it just feels like it completes my health journey, and it's something that I'm able to stay on top of.
No, yeah, absolutely. And I think that's a really good segue into how do you set those expectations? This is for the clinicians on the panel, you obviously had some very interesting factors in there, with your mom being adopted and other cancers in your family. And it seems like that was a really clear path for you. But for others, maybe who don't have such a clear path, for our two esteemed doctors, how do you set those expectations for people um, when they're trying to make those decisions?
Is your question about setting expectations for getting germline testing or about sort of how to help people through this journey from a new diagnosis and to where to go with their lives?
I think it's more along the lines of questioning, is this a good path for them, given all of the factors, is that information going to help them, because Casey, you just said, it opened your eyes, you're able to have conversations with your siblings, you're able to learn about other cancers that
Sure.
you could be, predisposed to. It obviously gives you, we always say knowledge is power, right? It gives you the tools to kind of navigate this. And when you're talking to someone, how do you kind of set those expectations of, this is a good path to go down for you, or maybe this information won't help you as much. How do you kind of set those expectations for people?
Everybody comes to their diagnosis kind of with their own life journey that got them there.
Mm-hmm.
And some patients are going to need to have as much information as possible because knowledge is empowering. And in those folks, we'll actually even spend time talking about where the field is moving and what is the field going to look like 2 years from now, 5 years from now, with the advances in cellular therapies and other types of treatments that are being developed. Others just want to be told, what should I be doing on a day-to-day basis, and let's leave it alone. And so you kind of meet the person where they're at and provide them with the amount of information. If there's something where you're really worried that there might be an inherited or heritable syndrome that could have impact to other members of the family, I'll raise that from this isn't just for you. You might be 65 years old, but you also have a brother and you have kids and grandkids and nieces and nephews, and this could be impacting towards everyone. If we learn this, then we can expand that information to those, and you could potentially help them that way. But that's really it's a individualized journey. Everybody,
Mm-hmm.
we want everybody to do well, and we want everybody to have as emotionally stable a process as possible. There are ups and downs of survivorship with cancer. There's the unknown of the next scan, or why am I having this weird pain, or what else is going on, that you have to constantly kind of use your mind to say, okay, I'm not going to let every stub toe make me afraid that there's a recurrence. I have to contain that. And how do you do that? And people use different techniques and different approaches. And then many really like information and data. And so as much as we can provide information, whether that's an imaging scan for somebody that's appropriate for, whether it's molecular disease, residual disease monitoring in patients that's appropriate for, if it's really about, hey, we got past this one. This is a really low risk lesion. We're not going to have to do anything, but this is the wake up call to see your dermatologist more. That would be another thing to be able to provide to them.
Yeah. Very personalized, right? Personalized medicine, personalized conversations. We all come from
Personalized
different
journey.
backgrounds. Yeah. Yeah, absolutely. Well, let's talk a little bit about follow-up over time and blood-based monitoring. Um, so, Dr. Krainock, I will go over to you first. Can you explain what ctDNA/MRD testing is in plain English, starting at like a sixth grade reading level? Because there's certainly a lot of information out there.
Sure. So Natera has a ctDNA MRD test called Signatera. And what that is a tumor-informed ctDNA test. What tumor-informed means is that we take a piece of cancer and we do a sequence on it, and we find variants that are unique to that patient's cancer. And then we look for those variants in the patient's blood. So that's really essentially what the test is finding genetic variants unique to a patient's cancer, and then drawing a patient's blood longitudinally or serially over time and looking to find those variants, and then asking, if we do find them, how much of them are around. So that's kind of essentially the way the test works. Now, that can be applied across all stages of disease, really, for various clinical use cases. So, if you've operated on a patient, what you'd like to see is that if you can't see any more disease and you've completely taken the disease out, you also can't find the signal in the blood, right? And what we're finding is if you can find the signal in the blood, that patient has a higher risk of recurrence than someone who does not have the signal in the blood, all other things being equal. And so you may be able to use that information to help make good personalized clinical decisions after resection, for example. In patients who are on systemic therapy for, say, metastatic disease, we use the test to kind of predict how a patient's going to do with more of the same therapy. So in other words, if you're on a certain drug for, say, metastatic disease, what we would traditionally do is follow your progress with scans. And then we would change things if we saw things were getting worse on the scans. Well, what we're finding is that actually our test can tell you before a scan if a patient's going to have a progression on a certain therapy, and can we use that information to make decisions earlier. So you can use this across stages, and you can use it to support clinical decision making after definitive treatment, like a big operation, in patients who are in surveillance and have had complete treatment already before you start testing, and then in patients who have metastatic disease and are on systemic therapy.
Great. So I guess this goes to Dr. Poklepovic. Can you tell us a little bit about how this test, this technology, fits in with kind of like daily practice? I mean, people are still getting their skin checked by a dermatologist. They're still coming to you. They're getting scans. They're getting routine testing. How does this fit in for patients?
Yeah, I utilize this test a lot. I've seen it really be helpful in informing decisions and management, and really helping in two directions. So it can provide information about when you should intensify your management and your oversight. So say somebody's going along through routine things and now their tumor DNA is rising, and you don't have a reason for that. Well, if it's rising, I describe this test as a fingerprint of the cancer that we can detect in the bloodstream. It's as unique as a person's fingerprint. It's as personalized as it can get, because this test will only work for that patient for that cancer. And that resonates with patients to hear how personalized it is for them. And if I see a value that's going up and I don't have a reason for why it's there, I keep exploring and expanding the area, because melanoma can recur in very strange places. And so, I found tumors that would have otherwise been missed with routine and standard imaging, because we didn't stop looking with routine and standard imaging when the test was positive. And now we found those, we've treated it, and those patients have now cleared their tests again. So that's the intensification side. I'm going to get different scans. I'm going to improve monitoring, or if somebody's on therapy, we might move up scans, or even talk about what we do next if the therapy is not going to work. And then on the other side, which is equally important, is de-escalating therapy, or de-escalating things that you're doing. Somebody could be on treatment. They might have disease or had stage 3 disease, or in remission, or have stage 4 disease, and they're doing well. They've cleared their tumor DNA, and now they're running into side effects from treatment. And as we all know, immunotherapy can have long-lasting side effects, permanent side effects, and dangerous side effects. And so for a patient who's coming to grips with that emotional struggle of, this is the drug that has saved my life, and now the doctor is telling me I need to stop this, I'm nervous about that. But if you have data that says, look, you cleared your tumor DNA 6 months ago, and you've now got multiple serial negative tests, I'm worried that if I push giving you more therapy, I'm going to give you more side effects without giving you additional yield. And we can use this test as a way to justify de-escalation for you, because you're doing well. We've got risk here. We don't need to continue adding the risks of therapy, because we have good information about how the disease is doing. So it moves in both directions. And, one day you could see where these types of blood tests are used throughout cancers. for monitoring whether who needs adjuvant therapy, how long they need it, when can people stop, when do people need more, when do people need less.
Yeah, it's a really good point. And as you're talking, I'm thinking, what about the person, this is an emerging technology, and what if their tissue wasn't banked when they had their initial appointment and surgery and everything? Is this test still applicable to somebody like that, or do they need to have that initial tissue in order to do the test?
This particular test is informed by the original tumor tissue.
Okay.
So in this iteration, what they're doing is they're analyzing the tumor to say, these are the things that broke, these are the things that we're going to track. And if you don't have that original piece, you can't find the things that are broken to then make the personalized test. But as technologies advance, might there be ways to circumvent that? Certainly it's an exciting field of minimally invasive, minimal risk cancer monitoring, which is a great strategy when you think about how often we get scans on people and for how many years we do that for.
Yeah.
Absolutely. And go
Oh,
ahead.
sorry. Go ahead. I was just going to add to that. Tissue availability tends to be less of a problem in melanoma. I would say the good news is that we could design against a variety of tissue sources, and it doesn't really matter where you are in your cancer journey in terms of when that tissue was taken and when we get it. So what I mean by that is we could go way back in your history and get a biopsy specimen or a surgical resection specimen that was obtained years before we ever considered starting testing in you. We can also do this from tissue taken from a variety of different biopsy types that are common in melanoma: excisional biopsies, punch biopsies, incisional biopsies. As Dr. Poklepovic has pointed out, the future, may very well include solutions that don't require tissue. But in terms of really precise clinical performance, the standard of the technology today is to use tissue when you can. And we can use a variety of different tissue sources to accomplish that. So just to add to that.
Yeah, no, that's great. And as you're talking, we educate patients along their journey. And I think this is just another piece, right, for people to ask their physician early in the process, right, and be able to track these things so that this is another option for them. And I think, that segues nicely back to you, Casey. What would your advice be to other survivors, in terms of testing, and how did that conversation go with your oncologist initially?
Yeah, it's a great question. I am one of those that for Signatera, my tissue block wasn't available. So I wish I would have known, right? I think that this field, as both the doctors have mentioned, is very quickly changing. I've also, when in doubt, seek a second opinion. I've moved dermatologists, moved oncologists multiple times, and I again, I didn't know hereditary cancer screening was available beyond BRCA patients. I think it's something it's a misconception. I think sometimes it's scary for people to know, like, oh my gosh, am I going to flare up with like 12 different cancer markers? You don't know. But I think that it does give us as much context and knowledge as possible to have a full picture of your treatment path. I consider myself very young, so I look at, the full trajectory of my life that I want to have. My mom didn't have that ahead of her, and just how much has changed since her diagnosis, and really what's to come in this future, beyond, putting on sunscreen and wearing the long sleeves, that there's so much more to this journey. And it's taken me a really long time to talk about my survivorship because there's so many pieces to it. I go to my oncologist this Thursday, so it's something that pops up every quarter for me, and I'm grateful that I have this in my back pocket because I think that it's changed my journey altogether, my mindset towards it.
So what do you do in between visits? Because we talk a lot about scan anxiety. We talk a lot about sort of the anxiety between seeing your physician. How do you deal with that?
That's a really good question. I leave every dermatology appointment with another biopsy, and it's just a lot of inhale, exhale, knowing that once that biopsy is, quite literally in a tube out for testing, there's nothing I can do. So I think it's really understanding what's in your control and what's not in your control. Um, Beyond what, making your appointments and, your blood, all the blood polls, my MRIs. So I think it's really trying to live my life. It's taken years and years and years to reduce that anxiety. I think that talking about it does help. I think providing accountability and just those friends to be like, hey, this happened today and I'm nervous. I had my MRI scan for my pancreas today and I'm nervous. Um, and when that you see the phone call come in and you're in the midst of a meeting and you know if it's going to be, hey, you have melanoma again, or hey, this is clear, or hey, we're going to have to take another margin. Um, I've also transformed my mindset around scars to just, battle scars. I think I used to, gosh, another scar, right? Something else to monitor, another proof that this is, part of my survivorship. So I think changing that narrative too. But it's a day by day and a week by week, and all these appointments line up at the same time, and just building your community and your village. I feel grateful that I can talk about this not just at home but also at work. That this is something we talk about, um, and I don't do this in my day-to-day job, and it's just something that I feel it's pretty incredible that I'm a patient but also an employee for a company that's bringing this technology to light.
Yeah, there's a lot of hope on the horizon, right? A lot of
Yeah.
hope, which is great. Um, Dr. Poklepovic, what communication tip would you give to your patients to help kind of align that care team? I feel like this is such incredible emerging technology, and you see a dermatologist maybe at one institution and then you're seeing an oncologist in another. Like what tip do you give people to kind of help align all that communication to lead to better outcomes ultimately in their journey?
One of my strategies is to really have relationship building with the referring provider community.
Hmm.
I get out to the community to talk to the dermatologists about advances in the field and how we approach things. We've pivoted largely to neoadjuvant therapy for clinically detectable stage 3 satellites and whatnot. And that's the kind of thing that information has to get out into the community quickly because the impact factor of starting immune therapy before surgery as opposed to after is big. And so recognizing that the pace of medicine moves quickly, my philosophy is to communicate to all of the dermatologists that I engage with in the catchment area and give talks to the Dermatology Association annual meeting to prepare them. And I always try to have talks about what do I think is so exciting about the cutting edge of oncology research. And biomarkers are something that people really like. And so the dermatology group is actually aware of these and they now are starting to ask, hey, are you going to get that on this person? Is this somebody who's it looks like they're a high risk early stage melanoma? I know you can't get them treatment, but can you survey them with something else in addition to imaging? And so that helps the patient really feel confident in their journey as they go through that because they're hearing sort of this communication when they're not in the room between their doctors about how we coordinate your care to optimize your outcomes. And that gives people an extra sense of security that the team is truly talking and working on their behalf. And so that's one strategy. Additionally, every physician should be providing their records and what it means. So I put a little definer of what MRD testing is, how it works into the documentation in my assessment and plan so that if they are intrigued by it, but I haven't had a chance to reach out to that person directly, they can learn about it on their own as well. They won't see those reports necessarily. That's something that the patient gets or the provider gets. But I have reached out to dermatologists if somebody's developed a positive value, and we've got, a couple of longitudinal tests that say, hey, there might be something really going on here. Can you help me take a look, do a total body skin exam, look for a bump somewhere that I might have missed that might be under the skin somewhere. Let's see what we can find.
Really great tips. And I mean, the community is lucky to have you that you're, jumping over the fence into the dermatology world and helping to educate them because I think that's huge. You guys go to different conferences and you learn different things. And this is clearly a technology that benefits patients who are seeing their dermatologist every year and, are at higher risk for melanoma. So I think that's fantastic. I just want to wrap up with one question. A lot of the people who are going to log in and view this are melanoma patients or caregivers, and the caregivers are often the ones that are helping to direct the care and are asking questions. Can you each give our viewers one practical action that somebody could take this week to feel more in control of their melanoma care? And Casey, I will start with you.
It's a tough one. I think it's so personalized for everybody. I think that I think just making a list of what you can and what you cannot control. You can control how long you're out in the sunshine, what you wear, and your attitude around it. But I think just being really pragmatic about what you can and cannot control. And then I think that more than anything, what I've realized is that melanoma is an additional community that I have found for this. During my initial diagnosis, I felt very alone. The person I would have wanted to go to was my mom. So I think that finding community in this, whether that's somebody else who experienced it or just someone you can talk to about it, is super, super powerful.
Yeah. Thank you. Dr. Krainock?
I would say, discuss the tools we've talked about today with your provider if you're not currently undergoing molecular surveillance. Get their opinion on the tools that are available. Understand how they might provide value for your personal journey and where you may be on it. And just understand what's available from a molecular surveillance and molecular treatment personalization perspective. That if you took things away from today that you didn't know before watching this, follow up with your provider and discuss them. And if they have questions, send them our way. One of my primary jobs is to get on calls and discuss where these technologies may fit in a particular patient's journey with providers all over the world. So you could feel confident that we'll support you if you do want to have these conversations with your provider.
Great.
Those are both great points. And not to reiterate them, I'll add a third thing that people can do to kind of feel more empowered and in control. And one is, for me, is pay attention to the advances in the field. Not that you have to be a medical expert and understand all the jargon, but to see the advances that have been happening over the last 10 years in melanoma and the outcomes and how much better, how much more of a survivable disease this is in 2025 than when I started in 2010 before ipilimumab had its first, Yervoy had its first, moving of the needle. And now we have many patients becoming long-term survivors from advanced disease and many more therapies right around the corner. And I always tell people, why do I do academic research? It's because the cutting edge is where hope is. That is where tomorrow's breakthrough therapies are. And if you are paying attention to what's happening in melanoma, even cursorily, you'll see that there are so many exciting things under development, whether you're injecting viruses into tumors that stimulated immune spots, whether you're modifying T cells, whether you are forcibly engaging immune cells, and on, the different approaches, each one can work when nothing else did. And that is important to know because the fear that you carry with you is the fear that you had when you were first diagnosed, when the outcomes were worse, and it continues to get better. We're better at monitoring, we're better at treating, we're better at figuring out what we need to do for individual patients on the basis of their tumor. And that provides everybody with more solid footing for getting through a difficult period of their lives.
Absolutely. We say research creates hope and hope changes everything. And I think that's what we're seeing in melanoma, right? And
I fully agree.
really, really great conversation today. I want to thank all of you for taking time out of your busy days and helping to educate our community. And Casey, we're rooting for you and we wish you continued good health and just really appreciate you being vulnerable and sharing your story. For everyone else watching, we have a lot of resources on our website, melanoma.org. We encourage you to visit our website where you can access our patient forum as well as many other different educational webinars and literature. And again, just a very heartfelt thank you to the three of you joining us today.
Thank you.
Thanks for having
Thank you.